Hello, everyone. It seems like people are wrapping up from the morning and we are continue to have participants trickling in. Welcome to our April 2024 webinar for the UCSF CalMap. For our April session today, the topic is substance use disorder. My name is Holloway Wayne. I'm one of the child psychiatrists staffing the CAP consult line. I also help organize our CME and educational activities, along with my colleagues, Drs. Joan John and Lauren Schumacher. We now have a new name. We're no longer CAP, but we're still the same group and same service. CAP is now called CalMap, the California Child and Adolescent Mental Health Access Portal. For real-time consultation that includes clinical, personalized guidance on how to apply what's taught in our webinars today to your own patient care, please call us via phone or online, and here are the phone number and our new website. We also now offer monthly webinar series recordings for the on-demand webinars. So if you don't have time at lunch, you can view our webinar recordings on your own time and answer questions afterwards. If you get a passing score, then you can still get the 1 hour CME and 1 hour AAP MLC Part 2 credit for each webinar that you complete. I also have a few housekeeping items. Today's session will be recorded and then posted on our CalMap website for viewing afterwards. If you have any questions for our expert, Dr. Holloway, today during or after the talk, please use the Q&A feature in the webinar, and we will try to save at least 5 to 10 minutes to answer these questions live if possible. For the interest of time, and we have a good quorum here to start with, I'm going to go ahead and introduce our speaker. It is a pleasure to welcome our expert today, Dr. Holloway. Dr. Ellen Holloway is a UCSF Department of Psychiatry assistant professor and licensed clinical psychologist. He's an attending psychologist in the Wavefront Outpatient Cognitive Behavioral Therapy Clinic at the Nancy Friend Pritzker Building on the Mission Bay campus. He has advanced training in pediatric and forensic psychology, substance use disorder treatment, including motivational interviewing, family checkup, and services research. Dr. Holloway provides clinical supervision through the Multicultural Clinical Training Program at the Zuckerberg San Francisco General Hospital and a research supervision through the Clinical Psychology Training Program and Juvenile Justice Behavioral Health Lab. His research focuses on improving behavioral health and legal outcomes for youth and families involved in the legal and foster care system and service access for publicly insured youth. With this, let's welcome Dr. Holloway.
Thanks so much, Eileen. I appreciate that. Really happy to be here. So just want to go over disclosures. No one involved in the planning or presentation of this activity has any relevant financial relationships to disclose. CalMap is supported by HRSA, as well as the California Department of Healthcare Services. All right, and with that, let's get started. So learning objectives for today are that by the end of this, you'll be able to identify 2 pros and cons of implementing substance use screening in your setting, and that you'll be able to understand the screening, brief intervention, and referral to treatment or expert model. And then finally, you'll be able to identify at least 1, probably 2, substance use screeners that could be integrated via the expert model. I want to start with just some positionality about myself, kind of give some background about how I approach this content, where I come from. So I identify as a biracial cis man. I'm often seen as white presenting. I was homeschooled and I grew up in the Midwest. And that does relate to some of what I'll present today, actually. I have interest in substance use, behavioral health care access. We'll talk about some of those today, especially gateway providers, which you all are. I don't know if you're familiar with that term, service delivery systems, and with a specific focus on system-involved youth and families. And I have lived expertise as someone who I was homeschooled. Growing up, we didn't have a lot of access to physical and behavioral healthcare for various reasons. And so I do have some lived expertise that I'm bringing to this topic as well. So I'm going to talk about a few models to get started. So the gateway provider model is really essential when we think about how kids get access to healthcare. And so they rarely, if ever, access healthcare on their own. And when they do, it's usually through an adult who supports their help-seeking behavior. We call this person a gateway provider. There can often be multiple gateway providers. So you can think about people who would be familiar with a child or adolescent, their needs, what kind of their sort of normal functioning is within person. So that could include a parent, a teacher, neighbors, probation officers, and primary care providers. And so there are a few different factors that influence how this gateway provider, and here this model or this figure is really thinking about people in a professional role, such as yourselves. So there are some enabling factors, right? The availability, accessibility, affordability, and acceptability of services. The needs for that individual child you're working with, what type of disorder might be present, the severity, comorbidities, and the level of impairment. Finally, there are some structural characteristics that influence someone's ability to be a sort of an effective gateway provider. And that includes your perceptions of different types of illnesses, knowledge of resources, and all of that influences a decision to provide or connect someone you're working with to services. Want to introduce another model that really influences the way I think about this topic and really anybody who's working with kids. The bioecological model by Bronfenbrenner and Morris really highlights all of these different systems that influence development and also health outcomes. So you can think about in the middle of this sort of onion is how I think about it, is the individual. And so there are biological predispositions and other characteristics that are sort of immutable, like age, right? Strengths and also some unique vulnerabilities that influence development and health outcomes. The level, that's sort of closest to the individual child is are these various microsystems. So early in childhood, family plays probably the biggest role, right, in development and influence on those outcomes. And as kids develop and on this trajectory towards adolescence, peers become more important. There's also interactions with school systems, healthcare services, right? That's where you all come in, and other institutions. And so these microsystems are most proximal to the individual child. And we're going to talk a lot about influences at this microsystemic level. So I want to jump right into one of the most important microsystems I just talked about. We're going to review some findings from a meta-analysis on some modifiable parenting factors that are associated with alcohol use in adolescents. First, I want to look at initiation. So to broadly summarize, some specific alcohol-specific parenting factors that are associated with initiating alcohol use in adolescents include talking about alcohol. And this can mean both sort of in like a positive light and a negative light. And so there's some research showing that parents who even talk about really risky drinking that they engaged in as a child actually can increase initiation, even if it's like a bad story. Parents' favorable attitudes towards alcohol use, their own alcohol use, and one of the highest sort of risk factors here is provision of alcohol. Makes sense. Also, if there are no rules about alcohol, if there are rules about alcohol, that's also associated with lower risk. In terms of other general parenting factors, parental monitoring, involvement, discipline, and a higher relationship quality are all associated with lower risk, with family conflict being associated with higher risk. I want to highlight these are really small effect sizes, so it's really probably a combination of many of these things, and it's important to assess these at an individual level. Now let's look at some of these modifiable parenting characteristics associated with continued use into the future. Provision of alcohol is really sticks out here in terms of higher risk for prospective use. Again, parental alcohol use and favorable attitudes. On the bottom, in terms of other general parenting factors, parental monitoring really has sort of the largest effect size in terms of more parental monitoring being associated with lower risk for prospective use. All right, so now we're going to look at sort of the next layer of the onion in the bioecological model, and that's the exosystem, which includes things like mass media, politics, neighborhoods, and the mesosystem is sort of this middle ground between the microsystems, the family, schools, peers, and sort of this broader society. And so some examples of this type of influence and substance use can include microaggressions, oppression that youth may experience, right? And coping is one reason why teens may initiate or continue to use. And also there's increasing acceptance of in California, cannabis, like legal cannabis markets, right? And also exposure to substance use on social media. And so it's important to look at these influence as well on the initiation and continued use. Okay, so I want to talk a little bit about, okay, I want to talk a little bit about the stages of change model. This is really relevant to consider how you might interact with patients that you have and for their willingness to work on substance use if it is a problem.
The trans-theoretical model, also known as the stages of change, represents a person's readiness to change. There's 6 stages. These are pre-contemplation, contemplation, preparation, action, maintenance, and relapse and lapse. Today, we'll look at the model in the context of alcohol and other drug use. Identifying where a person might be at in the change process can provide some direction as to how they can best be supported. Let's take a closer look. Pre-contemplation. People in this stage aren't worried about their use. They're not interested in stopping or cutting back. Even though other people might be concerned about their use, for them the benefits far outweigh the consequences. Contemplation. People in this stage of change still enjoy using. However, maybe they're starting to notice some problems from their use. They're weighing up what changing might mean for them. Preparation. This is when the not so good things about using are starting to outweigh the things they enjoy about it, and they begin preparing to make a change to their use. Action. They've started to make changes to their alcohol or drug use. It will depend on the person's goal, but this might include things like using less or stopping. Maintenance. They're maintaining this change. They've been in the action stage for long enough that change has become easy. They've got this. They're no longer dealing with constant cravings and triggers and have maintained their goal for a significant period. Relapse or lapse. A relapse is a return back to using, and a lapse is a slip-up. A lapse does not automatically lead to a relapse. Both lapses and relapses provide an opportunity for the person to learn more about themselves, what triggers them or challenges them, and what promotes opportunities for growth. It's really important to help the person see any lapse or relapse as a learning opportunity as opposed to a failure. People learn a lot more from their setbacks than from their successes.
I just realized I was muted. I'm sorry. I was saying it's important to consider where clients might be in these stages when you identify some substance use or really any health behavior that they might consider changing. And so the goal is to figure out where they are and then to consider if they're ready to move forward to a different stage of change. Okay, let's talk about prevention. So there are different strategies that you should consider really at all of these different levels. So the first is universal prevention, right? So this is where we're looking at preventing substance use at the population level among all kids and adolescents. Then selective prevention really focuses on those who might be vulnerable to developing substance use problems based on identified risk factors. And then indicated prevention, and this is where there might be early signs of substance use problems. All right, this comes from the Matson article citation I had on the left. There's a lot here, and so I just want to draw your attention to some examples of universal prevention. So this left column highlights kind of the easiest or the least demanding or resource-intensive activities you could think about engaging in. Screening is top of the list. We're going to talk a lot about screening today, but it also can include providing information, talking with parents and adolescents, and or referring them to outside resources. Next, we have selective prevention. And so again, this is where we might want to monitor for needed prevention and consider making a subspecialty referral. Talk about different types of treatment referrals one might make. And then finally, indicated. And so this is where we're more confident that we need to make a subspecialty referral or consider that, and then figure out where we might send them. All right. Going to orient you to another framework here. This is the cascade of care. And this example comes from, is actually highlighting the opioid use disorder and how we might identify opioid use disorder and sort of move from left to right. So if you draw your attention here to the left, you can say these are sort of estimates of the general population, right? Where you might want to engage in primary prevention of opioid use. Secondary prevention is where there is some risk of using opioids or someone has started to use opioids and you would like to prevent it from progressing and or reduce that use. And so basically, as we move from the left to the right, you can see that we have an estimate of opioid use. Those who are diagnosed, right? There's this blue line kind of shows the current estimates based on epidemiological data of how many people are getting diagnosed versus sort of 90%. This red line highlights like if we were to get 90% of those who probably have opioid use disorder, here's how many we'd like to be diagnosing, right? So this red line kind of represents the gap. If you're diagnosed, then you should be linked to appropriate care, right? And so we can see that the estimates of those who are actually linked goes down. So that's getting linked to care. That's not actually starting with treatment. Even fewer will actually initiate medications for opioid use disorder. Even fewer will stay engaged in treatment 6 months later. And even fewer will sort of see those benefits of recovery. And so this is a helpful framework to sort of think about at how we go from population level to how we identify people who might have problems with substance use disorder, engage them, and sort of see those benefits. This is relevant to HEDIS metrics, right? So the initiation of treatment and engagement in treatment are really important for us to consider. So one solution to sort of support this identification and triage and connection to care is the SBIRM model. It's an acronym, right? So it starts with screening. Why do we want to screen? We want to identify all use with kids that we work with. How do we do that? Through evidence-based, standardized brief screeners. We also, you might use some substance use specific screeners, which I'll talk about. There's also some frameworks, which I'm not a pediatrician, but I've learned about like the heads and the shades screening sort of frameworks that you might use to sort of ask more informally or at least standardize talking about substance use when you're meeting with clients. If we do, or once we have our screening results, you want to consider a brief intervention. Why? Because people only change when they decide to, right? As was highlighted in the stages of change model. How do we do this? Through providing brief advice or motivational interviewing. And then if the person could benefit from treatment, they are in agreement that they would like to consider changing that behavior or maintaining abstinence, right, or sort of harm reduction, then you make a decision of, okay, should we consider referring to treatment or other supports? Really only want to refer to treatment when the brief intervention isn't enough. How do we do that? By developing a menu of services and then matching the services to that severity of the current need. So SBIRT is great in practice, it's a great idea. And we also know that in practice, there are some barriers to implementation among pediatric primary care providers. Some of the biggest barriers that have been highlighted in research in a national sample of US pediatricians is confidentiality issues, right? So this could be broad, but consider who's going to have access to the screening results, the mode of collecting, of sort of implementing screening, where are you going to have this brief intervention, how do you get kids connected to treatment while respecting their confidentiality. Insufficient time during appointments. There's a lot of things that you're asked to cover in primary care. And frankly, this might be a lot, right? And so pediatricians have reported they just don't have enough time. About 38% reported they feel like they have a lack of expertise managing substance use in practice. And about a third say they're not sure if they know enough, right, about the substance use resources in their community. And then about a third also report there's limited opportunity to talk with an adolescent without a parent present. Okay, I'm going to jump into examples of some specific substance use screeners. So here is the screening to brief intervention. It's really 3 questions, right? So you ask a single frequency of past year's use of the 3 most common substances used by adolescents: tobacco, alcohol, and cannabis. So if an adolescent says, yes, I have used alcohol, I've drank alcohol once, right? Then that would be categorized as sort of lower risk, right? But it's not a no risk, right? If an adolescent reports that they've used any of these substances, then they're actually prompted to ask about other substances. For example, maybe amphetamines, cocaine, opioids, things that are less common, but more potentially dangerous, right? This screening to brief intervention has been validated with a sample of 12 to 17-year-olds, and I've included a link here. And I want to say these are not the only screening instruments, right? There are many, but both of these are evidence-based and widely used, and also available on the NIDA website. You might be more familiar with the CRAFT. The CRAFT is a little longer, a little bit more detailed than the S2BI, and there's a few different ways that you can do this. You can administer it as a clinician, but research shows that you actually the CRAFT is most effective in really all screening if you're able to integrate it into your practice where kids are actually answering these questions on their own and sort of in private, right? And that also helps to standardize it if they're doing it on a tablet or something in the waiting room or before they come to your appointment. So on the left, the CRAFT also asks about how many sort of frequency, right? How many days you might have used alcohol, cannabis, or anything else. Also in this most recent version, the N, right, CRAFT 2.1 N stands for nicotine. So asking about vaping is also included here. So similar to the S2BI, if the client says, no, I haven't used any of these substances, then the only question you would ask is this question: have you ever ridden in a car driven by someone, including yourself, who is high or been using alcohol or drugs? If they answer 1 or more for these first 3 questions, then you want to ask all 6, right? 5 through 10 over here as sort of the follow-up. If they say that they vaped, then there are 10 other questions in part C. I didn't include that here, but you can find that on the link above. So let's say we get to we get to the point, right, where we're asking these questions over here on the right. What do we do with that information? Here is some guidance, right? And so research has shown that sort of cutoff score of 2 or higher is sort of the optimal cut score for identifying any substance use problem on the CRAFT. You can see the sensitivity, 0.76 is pretty good. Really high specificity, which is important for a screening. You want to make sure that you're not missing anybody, right, who might have a substance use problem here. And again, this is just a starting point to figure out kind of where to go. One thing before move forward, just want to highlight that while these are both sort of brief screening instruments, you can see that the craft is a little bit more complicated, right? To kind of figure out like, okay, if they say they've used, 0 versus 1, on one day they've used this substance, the algorithm can get a little bit tricky to do in practice. And so automating it and or getting a lot of practice before you're using it in the real world is really important. This also might have implications for what you choose to do in your practice. All right, let's look at some more data on how screening actually works in pediatric primary care settings. So this was a sample of geographically diverse pediatricians who reported working with adolescents across the country. This was from the AAP periodic survey. And so of those who participated, they found that about 60% reported always screening adolescent patients for substance use, and less than half, about 42%, used a standardized instrument like the two that we just covered. When screening did occur, the Western region of the United States, where we are, in relation to the Northeast, whether that's the appropriate reference, I'm not sure, but that's what they used. In comparison to the Northeast, primary care providers in the Western region of the United States were less likely to report always screening. And we're also less likely to say that they usually screen using a standardized instrument. About half administered paper-based screeners, and it was unclear from the abstract what the other methods would be, but I presumed that those meant electronic screening or verbal screening. About 3/4 said that they screened without a parent present. And I know, I'm not sure, this could be a short teenager, but I just really like this graphic because there's some measurement, and I also thought we actually should be screening, for some risk factors with younger kids, not just like some predetermined age when they we sort of decide, right, that we should implement screening. Okay. In that survey, they also looked at reported barriers to adolescent substance use screening. And so just going to highlight some of the things that stuck out to me, but I invite you to draw your own conclusions as well. One of the biggest barriers was that there were no on-site providers for counseling. So once you do find a substance use problem, what do you do, right? And not having someone right there was a huge barrier. Similarly, for treatment options outside of their site. About half said that they thought that patients would be reluctant to discuss it. And many also said that they felt like they had a lack of knowledge or expertise in this area and needed more information. That's one of the reasons we're doing things like this webinar, is to help provide some of that context and improve comfort. Others said there's too many priorities, right? And fewer said that there's a lack of time. And I think this last line was really striking to me because almost everybody, right, maybe like 85% or so, disagreed with the fact that they don't think it will make a difference. So considering all of these other barriers, right, pediatricians are saying they actually believe that screening will make, should make a difference, right? And there are all these barriers that are getting in the way. Okay, so now we're going to talk a little bit more about motivational interviewing and what to do based on screening results. Here is, I'm not going to go into great detail on all of this. Here are just some highlights on kind of what to do, and you'll get this resource. This is from the Massachusetts, expert.org. Oh, sorry, I have a very touchy mouse. There we go. Okay. So what do you do if there's no use? You want to reinforce, provide some affirmation, right, for the decision not to use that drug, provide education. And so this elicit, provide, elicit sort of method is really central to motivational interviewing. You telling them, here are what the risks are of using substances is less effective than asking what they know, and then asking for permission to share some information with them. With their permission, providing some of those risks, and then eliciting what their thoughts are on that. Getting them to think about the future, right? Because we know that adolescence is, and then into young adulthood is one of the primary developmental stages for the onset of substance use. And so even if they're not using at that point, getting them to think about the future, certain situations where they might, and what might change, right? Okay, so let's say you do identify some use. Here's some guidance to help kind of lead. So not going to get into every line, but here are the broad steps. You want to build rapport. Again, ask about them and their use. Get sort of like a typical day. Explore the pros and cons of using versus not. This is the place where you might provide some of the screening results, which again is in line with motivational interviewing principles, because you're basically taking what the information they provided and reflecting it back to them. With permission, providing some feedback, and then using a readiness ruler, which is here on the right? Like, how important is it to you to change? How confident are you if they do want to change, right? How confident are you that you could change? And then based on everything you've learned, coming up with an action plan with them to consider. Now, it's really important to remember that you might identify some uses like this is problematic, right? Or I'm really worried about this, but it's important. It can actually really shut down that conversation, right? If you come in with seeing like you're telling them what to do or what's important. So it's super crucial to elicit this from adolescents. I want to watch another brief video here. I thought this was a great example of summarizing a lot of what I just said in a short amount of time.
Alas, it would be impossible for me to teach you all the skills inherent to motivational interviewing in this brief video. Instead, I will focus on a few essential components.
Sorry about that. What's happening?
If you want to start a conversation with your patient about their substance use, ask permission. Patients with substance use disorders are accustomed to being criticized, ridiculed, judged, and berated for their behavior. So, by asking permission, you've already clued in your patient that this is going to be a different sort of encounter. So, Ms. Roberts, is it okay if we chat a bit more about your smoking? Next, ask your patient what they like about smoking. Patients only engage in addictive behaviors when those behaviors do something for them. Perhaps smoking helps the patient to relax. Perhaps they just like the way it makes them feel. Maybe it's just something to do during a break at work. Either way, providing your patient an opportunity to explain why they continue to do what they do tells the patient that you care about their perspective, and ultimately, it builds rapport. And hey, if your patient replies, "I don't like anything about smoking," well, you've just found something that the two of you agree on. Next, ask the patient what they don't like about smoking. Some patients may have a litany of things that they don't like about smoking, such as the smell, the cost, the health concerns, and the nagging from their significant other. You'll want to use reflective listening here, with plenty of mm-hms and "I see" and "tell me more about that," as well as just simple, silent attention. This ensures your patient has the opportunity to fully flesh out the negative associations they have with smoking in more detail. Of course, some patients may have very little to say here. This is your opportunity to gently ply your patient for the potential negatives they may not have thought of. Think about the potential complications of smoking. You might ask about any issues with chronic bronchitis or decreased exercise tolerance. You can also explore issues with hypertension, gastroesophageal reflux disease, and erectile dysfunction. Other questions to ask to coax the negative associations out of your patient include: do you have any family history of cancer? Are there conflicts at home regarding your ongoing substance use? How much do you spend each month on your habit? All these questions should be asked with a genuine curiosity and a non-judgmental attitude, where you are simply gathering data, to be used in the next step. Finally, ask your patient if they have ever tried to quit or cut back in the past. If they say yes, ask why. What led them to quit in the past? This detail may be the most important bit of information you obtain, since you know it was important enough at one time to have led them to make a quit attempt. Okay, now, armed with all that information, home in on the ambivalence. On the one hand, it sounds like smoking cigarettes really helps you to relax at night. But on the other hand, it sounds like smoking is costing you about $250 a month. You don't like the smell, and you're worried about this nagging cough you've had for the past several months. Seems like you are conflicted about your smoking. This statement draws attention to the patient's ambivalence and conveys to the patient a sense of compassion and an acknowledgement that making change is hard. After pausing to allow the patient to reflect on their ambivalence, move on to the question of how ready they are to quit. Ask, on a scale of 1 to 10, with 1 being you want to continue smoking exactly as you are, and 10 being you want to quit smoking right at this moment, where would you say you are along this scale? If the patient responds with any number between 2 and 10, your response will simply be, okay, you picked a 4. Why didn't you pick 2 or 3? By asking the question in this way, you're asking the patient to repeat the factors that are motivating them to contemplate change. In contrast to that paternalistic approach we described in the prior lesson, in which a clinician might say, stop doing that and shape up, or you need to quit, inevitably leading the patient to defend the status quo, with this new approach, you have now put the patient in the position of defending change. A patient who can defend change is clearly in the contemplation stage, so your next steps would be to try to steer them into the preparation stage.
That was about where I was going to pause it. But I thought that was a great sort of summary of a lot of sort of that process. And I saw in the chat a request for a role play. Love that idea. I hope that this video provided a little bit of that, right? So let's say that your client is maybe in the contemplation phase, considering moving into the action phase, or they're already there. Here are some things to think about for the next step, right? So we've done the S, the BI, screening, brief intervention. Now we're in referral to treatment. So on the left are sort of the different actions that you can take. I'm going to start at the top. To do nothing, right? So if this substance use seems normative, there is no risk identified, there's no impairment, it's not causing problems at home or in school, and it's a low clinical priority related to something else, then you might actually just do nothing. That can be best. One of the reasons is because, especially in adolescence, the importance of social learning on the brain and the influence on behavior is crucial in children and adolescents. And many substance use treatments can be like in group settings, right, with other kids who are using. And so doing nothing can actually be protective to some extent. Providing brief advice is probably the best move if the use is normative. There is no risk identified, no or minimal impairment, and it might be a clinical priority based on your judgment and what you know about this client. Outpatient treatment, sort of the next step, right, of like making an official referral somewhere, either maybe internally or elsewhere, is if you aren't sure if the use is normative, there might be some risk, right? There is some impairment that's being caused. And this is deemed a clinical priority, maybe on its own or along with other clinical priorities. Intensive outpatient is a pretty high level of care, right, in terms of staying in the community. This is when the use is clearly not normative. The risk is potentially life-threatening, or you could see it escalating there. There is significant impairment that's causing problems in one or more domains in their life, like school, at home or with friends, or their own sort of mental health perceived suffering. And you would only do this if it's definitely a clinical priority, sort of higher priority than other behavioral health and physical healthcare needs. Inpatient unit is the highest and most restrictive level of care. This is when the use is clearly not normative. It could be or is life-threatening, causing significant impairment, and it is probably the highest priority. With this sort of continuum of different actions you can take, you always want to consider the lower level of care, right? Can we have one lower level of care? Because we know that folks staying in the community is always best. Being at home generally is best. And those are the places where people are going to learn the skills they would learn in treatment and be able to apply them in the real world. And so even if you do decide that a higher level of care is needed, you always want to be thinking about what's the step down process to get to a lower level of care. All right, so let's talk about some of those different kind of sort of the severity, right, or the intensity, I should say, of interventions. Here's a couple of books that go into these in much greater detail on the left. So first, brief advice and reinforcement, right? So brief advice with permission about substance use, providing reinforcement when they are not using or have made attempts or are gaining some insight into why they might not want to use, providing some psychoeducation about the influence of substance use on their development, their behavioral health. Personalized normative feedback is basically, this is something that's used a lot in college settings for students who have gotten in trouble for substance use, where they have to, meet with a counselor or somebody and basically report what their use is. And then it gets compared to sort of kids their age or people who are similarly situated. One thing that's associated with more problematic use or increasing use is that kids may overestimate how many of their friends are using that substance, the severity of those substances, right? And or thinking that they're experiencing fewer problems, right, related to that substance than they are. So actually measuring their own substance use and then comparing it to what the normative population level data is can actually be a pretty powerful tool to show that sort of discrepancy. Motivational interviewing, which we just covered. And then sort of at the bottom, we have like a multi-session brief parent-youth intervention. And one example is the family checkup model. All right, so these are the not so brief interventions. Because we talked about the importance of the microsystems, especially the family, and the provision of alcohol by family members and family use might be appropriate to refer a family member to treatment. Next, cognitive behavioral therapy is something that could address some of the underlying mental health concerns that could be associated with some motivations for substance use. Contingency management, which is providing incentives and rewards for attending treatment or reducing use. And then these next two sort of levels are the more intensive ones. So intensive wraparound services, so functional family therapy or multisystemic therapy are community-based interventions that are very intensive and sort of come into wrap around the kid and their family in the community. We also talked about inpatient rehabilitation as sort of the last step. And if that is necessary, to be considering the step down sort of plan once they get started. Here are some other types of sort of interventions. We talked about family-based therapy, cognitive behavioral therapy as these well-established standalone interventions. There are some other types of interventions that could be helpful, right? For folks, 12-step programs can be helpful. And then other types of interventions or sort of services that, again, might be helpful sort of in addition to some of these other interventions, things like exercise, behavioral activation, mindfulness, and potentially pharmacotherapy. It's also important to consider the mode of delivery, right? And so can services be provided via telehealth or through like an app? And then considering whether or not these are culturally sort of appropriate based on what we know about our clients. I'm going to quickly go over some more in-depth, like specific interventions that you might consider if a higher level of care is sort of needed. Motivational enhancement therapy plus CBT can be about 5 to 7 sessions. The primary goal is to enhance motivation to change substance use, especially cannabis use is one of the substances that this has been most tested with. For alcohol, the ATTAIN model is about 7 sessions, similar, based on CBT principles to reduce alcohol and cannabis use. We're getting into some of the more sort of intensive services. Brief strategic family therapy can be anywhere between 3 and 24 sessions. And this is really focused more on the dyadic level, supporting parents and identifying conflict in the home, right? Communication skills that could be contributing to the substance use problems or inhibiting the recovery from them. Contingency management is one that I highlighted. This can be politically contentious, but the evidence is clear that this works very well and basically providing a reward system to reinforce certain behaviors like abstaining from substances or attending treatment. Familias Unidas is an example of a culturally responsive family-based intervention for Latina families. This is more intensive, 3 to 5 months. There might be multiple or like longer sessions, 2 hours per week. And then here are some other examples of the more intensive family-based sort of wraparound services: multidimensional family therapy, multidimensional treatment foster care, and multisystemic therapy is really the most intensive type of service that you could refer a family to. All right, so we've talked about SBIRT, all those different steps. And we also talked about a lot of the barriers to implementation. And so I don't want to simplify all that, but about this resource from the NIAAA was really helpful to think about how you might start implementing screening at a minimum into your practice. First, educating your office staff. So ensuring that staff members understand the importance of universal substance use screening. Identify someone who can be a champion to establish that protocol, monitor its effectiveness, and evaluate those procedures and how they should be modified, or what's working, what is not working. Decide how screening will be conducted. If you have dedicated staff, like someone who can help screen instead of the physician, right? That's one way to do it. Or you could print it out. Then there's other sort of complications there. Evidence is shown because kids are so technologically sort of literate, and because of the importance of providing a confidential setting for youth to report their use, adults too, a sort of computerized, self-guided screening can be before coming into the exam room, might be a really good way to consider this. But ultimately, you want to think about screening in any way you can, right? And thinking about what's feasible and what steps you might take to sort of enhance your protocol. Also committing to screening at every possible visit. Didn't find a ton of literature on this with adolescents, but in adults, evidence has shown that whenever providers screen at every visit, not just like, oh, I'm only going to do it at the annual visit, that actually is most effective at identifying emerging substance use. Setting reminders, so you could help incorporate this into your workflow, such as electronic medical records, right, to queue for screening, and then follow up with the last results from the last visit. Preparing for confidential care. So think about the logistics, the physical built setting for how you can protect confidentiality. In California, minors are age 12 and up are able to consent to their own substance use treatment, and that includes screening, right? And so you might want to think about how to set this up, because at age 12, you do not need parental permission to assess for substance use or refer to treatment or provide that treatment. Prepare for referrals. So generating a list of local adolescent substance use treatment providers, building rapport with them, and seeing sort of what the wait lists are. It's good to have a variety of treatment options, because inevitably you will identify higher severity cases and you need to know what to do with those. It's also a good idea to stock some materials and exam rooms, and think about other ways that you can sort of institutionalize your practice's focus on substance use screening, brief intervention, and referral to treatment. I've included some resources here that guided a lot of what I provided today. You'll get those. And then I just wanted to acknowledge Dr. Marina Tulu-Shams, who I took a lot of that promising or evidence-based interventions from her, the CalMAP team, and also my past clients, mentors and supervisors who have really provided me the opportunity to take my experience as a clinician and marry it with research, and also my family. So I want to thank you all for your attention and see if there are any questions.
Thank you, Dr. Holloway, for this very comprehensive review. And we do have a couple of questions that come up. The first one is very common. I think we all experienced it in our clinical practice, which is teens with substance use disorder who are not interested at all in any form of treatment. Their families are probably driving it, or their pediatricians are driving it. And then what will be your recommendation for approach?
That's a great question. And yes, I think a very common one. Motivational interviewing principles really are at the core here, right? In addition to identifying what the stage of change is. So what you described there is sort of this pre-contemplation phase. Like, I don't think I have a problem. This isn't something I need to change. I need to work on. And so I think you could identify, first get to kind of know them, what some of their goals are, and then to think about, reflect back on like what their progress is towards those goals, right? Currently or in the future, and to elicit from them, not just substance use, but really other factors, right? That might be helping them to reach those goals or holding them back from reaching those goals, right? And ultimately, this might not happen in one conversation, right? It might need to follow up and provide people the opportunity to kind of reflect on this, on whether or not they realize this is a problem, would like to make some changes. And so those are some things to sort of consider. The personalized normative feedback is another one that you could provide, right? Is to take their screening results on how often they're using, what they're using, and based on their age and sort of where they live, provide some data on how that relates to the population, right? And if there are experiencing a lot of problems, then it's likely they're using more than their peers, right? And so maybe overestimating. So those would be some places to start. And then finally, look at the family. I think a lot of times working with kids and adolescents, parents come and they say, oh, my kid's the problem, they have this going on, right? And so what's being modeled, right? So if parents are drinking every day, or often using other substances, or there's access, sort of intentionally or not, to those substances, removing the focus just from the adolescent and sort of thinking about the family in general and some changes that could be made is another way to go.
Thank you. It seems like we really should identify the stage of change in using motivational interviewing, discovering the goals besides medical concerns and treatment for substance use, but kind of move beyond that, focus on maybe a romantic relationship, their friend relationship with family, what else they want, improvement at academic performance, those type of things. The other question is, at what point would you feel you have to break confidentiality to tell parents about their level of substance use when it becomes endangering the child's or the teenager's health, and get parents engaged?
That's a great question. This, goes through the informed consent from the beginning, right? Where I will tell kids that I'm working with, like, here are the things that I am, I'll do my best to kind of keep between us. Here's the level of where I would need to tell your parent or somebody, if it's a safety concern. And so letting them know that before they do the screening and while you're having that conversation is really crucial, so that it's not a surprise that if there is a level of danger there, and you are going to need to disclose, right, or there is a higher level of care, that they kind of see it coming. And then another strategy I'll take is I will let adolescents know that, hey, here's kind of what my medical, or my professional opinion is, and also what I am legally required to do. And so we're going to have to talk to your parent. I want to talk with you to come up with a plan about how we're going to do that. Well, so let's co-create that together, and then bring everybody into the room and kind of empower the youth to say, hey, do you want to lead this? Do you want me to lead this, right? And if they ask me as a provider to lead it, I will say, please jump in if you disagree. If there's anything else that you want to add or provide some context there.
Yeah, so having that introduction to confidentiality at the very beginning of establishing care will be important, and also getting everyone's consent that they all agree with it.
For sure.
Yeah, and our next question, and likely the last one as well, is how do we best assess teenagers' use and then determine whether it's normative or not? If it's alcohol, marijuana, these things could have a fine line in terms of they only consume some alcohol when they're with families, but the frequency may vary. So when do we kind of call the shot?
Yeah, it's a great question. I mean, I think understanding the cultural context, their identity, right? And ultimately there's no fine guidance, right? This is kind of a clinical judgment, but it should be based on a listening more about what is normal within, you know, this kid's family or their culture. So, you know, taking a sip of wine at a wedding, cousin's wedding or something, right? Like there might be religious, cultural sort of undertones to that. Like I attended bar mitzvahs growing up, right? And having some Manischewitz was like something that my mom was like, yeah, like this is, you can have a sip, right? This is like a thing that happens at a bar mitzvah. And so, but there were also kids who would like steal a bottle and take it to the other side of the room, right? I remember. And so I think building rapport and understanding the kid's family and sort of their values is important.
And it seems like getting collateral information will be crucial because we'll be able to learn these backgrounds from their families as well.
Absolutely. Yeah, and parental monitoring is protective, but also really important to know what's going on, right? And so bolstering that and relying on collaterals is crucial.
Thank you very much. I think these are all of our questions, and thank you everyone for attending today's webinar. Here's some important information regarding your CME credits that we have put in chat. So please access your CME credit for today via the either by using the QR code. I think there's a slide regarding that information. And then there's a link that may posted in chat as well that you can access the CME credit. Okay, great. So see you in May. Our next topic for next month's webinar will be on May 9th on Thursday, again from 12 to 1 o'clock on the topic of youth social media use. And Caitlin Costello will be our speaker. So we're looking forward to seeing you there. Thank you again for your participation today. Hope you have a good month.